Okay. So let me know if you can't hear. Let me know if you guys have questions while we're doing this. It is recording, so you can save it for later and watch it again if you want. So this is obviously relevant to my disclosures, but so what am I going to talk about? Well, I want to talk a little bit about why we do carotids, okay, for asymptomatic, symptomatic patients. What is the difference between CEA, so traditional carotid endarterectomy, TCAR, and transfemoral carotid stenting, which is going to put a stent in by going through the femoral approach, and talk about the risks and benefits of each approach. And then I'm going to stop intermittently throughout because I want to go over with you guys some of the stuff for both the workup of TIA and stroke as it relates to carotid disease for when we get consulted. And most importantly, I want to talk about the medical management of these patients who are undergoing TCAR, because I think that's super important for everybody to be on the same page about. So why do we perform carotid interventions? What are our options and who are the patients that benefit? Who should get a carotid stent and what is TCAR? How is it different from traditional carotid procedures and carotid stenting? So how big a deal is stroke? Stroke used to be the number 3 cause of death in the US. It's now down to number 5. I think that's in part due to a lot of improved medication management, most importantly statin medication, as well as just decreased smoking overall in the country. However, there are almost 800,000 strokes per year with 170,000 deaths attributed to stroke, so it's a big deal. And most importantly for our patients, we have patients that are dying from a slow progressive or even aggressive cancer. That's usually not something that they pass away from right away at the index hospitalization. Whereas stroke can be both morbid and inducing a rapid demise, and so patients and their families are really scared of stroke. And I think as it relates to other things that can cause death, it's probably one of the more scary things for patients. That's been pretty well borne out by various quality of life studies. So patients are really afraid of having strokes. So if you have a stroke, your risk of death is about 15 to 30%, and your recurrent stroke risk is about 5 to 15% per year. And it accounts for a huge amount of healthcare expense. What are some of the things that we can do to prevent somebody's stroke that has nothing to do with surgery? So one of them is decreasing their blood pressure, right? So just getting their blood pressure under control. That's why it's important when we deal with our stroke patients. If we're getting a consult for a patient who doesn't follow with anybody in the community and doesn't have good medical management, it's really important that we make sure their medical situation is optimized prior to us going and doing something and concurrent with us doing something. So if we have to go and do a carotid on somebody in 2 days or so, we want to get cardiology involved. If they don't see a cardiologist, they've got uncontrolled hypertension. Similarly, there was a TCAR patient who we treated a while ago who had persistent hypertension afterwards. And I think it's important that we get cardiology involved because this was an interesting thing. Apparently, she was holding her amlodipine, which is what we wanted her to do because she was getting leg swelling. She was also holding all of her other antihypertensives from home as well. And then those never got restarted. So initially she was hypotensive, so that's why we held them all. But then she got readmitted to the hospital like twice in the course of a month with refractory hypertension. And when I finally touched base with the cardiologist, he was like, oh yeah, all of her medications had been held and it hadn't been restarted. So, I realize that's part of what we do is our procedure-based approach, but I think it's really important that if these patients have cardiologists, especially cardiologists that are here at Baptist, that we talk to them and say, hey, your patient's in the hospital, what do you think of their blood pressure after this procedure? Would you recommend we do something different with their antihypertensive regimen? What about smoking, as I mentioned before? So smoking increases the risk of an ischemic stroke by 25 to 50%, and quitting smoking obviously significantly reduces the risk of stroke within 5 years. Antiplatelet agents. We want to make sure that all these patients are on an antiplatelet regimen, and we want to know if there's some reason they can't be. That's probably the most important thing for carotid disease in general, and for TCAR, it's critically important. We cannot be doing a TCAR on somebody unless we have a good understanding of the type of platelet regimen that they're on. So, do patients need to be on aspirin? Do they need to be on aspirin and Plavix? If you just put them on aspirin alone, you see a significant risk of their non-fatal MI, non-fatal stroke, or any other vascular-related death. If you put them on Plavix instead of aspirin, you see a very mild relative risk reduction in their rate of stroke. So if they're on Plavix instead of aspirin, is Plavix better than aspirin? It's minorly better, right? So it's like 5.3% risk of stroke versus 5.8% risk of stroke. It's significant, but just barely, and it depends on how big of a trial. What about statin medication? So we want all these patients to be on statin medication. Even if they say they have statin intolerance, unless they have like a real contraindication to statin, like they've had rhabdomyolysis, but they've had hepatic failure associated with statin use in the past, we want to put them on some type of statin medication, preferably at what's known as a high intensity dose. Why is it so important? There's an absolute stroke risk reduction of 2.2% in 5 years, which is a 22% relative risk reduction. So if you look back at this last one, I said this was a 9% relative risk reduction. So more than twice that just by putting patients on a high intensity statin, basically double-blind placebo compared to 80 milligrams of atorvastatin. In diabetes patients, it's even more significant. The Carotid trial shows a 37% reduction in cardiovascular ischemia, 48% reduction in ischemic stroke. So when patients ask why they should be on a statin, sometimes you'll hear patients say, well, my cholesterol is not high, I don't need to be on a statin. And the reason we want them on a statin is because it stabilizes their plaque. So a lot of times you'll see patients that have a femoral plaque, right? You'll see a CT scan and they'll say they've got a common femoral disease, and maybe they've got claudication, or maybe they've got even like critical limb ischemia, they've got rest pain or something. However, we don't talk about that common femoral plaque embolizing, right? We don't talk about the reason that they have symptoms is because that plaque is causing emboli. And that's because common femoral plaque is very stable plaque. It can cause narrowing, and eventually it can cause occlusion. You can get thrombus formation there, you can get clot formation if it becomes very narrow. But it doesn't embolize distally down the leg. That's super rare. It happens on like once in a blue moon, but it really doesn't happen that often. But carotid plaques are inherently less stable, and they become less stable in part because of ongoing tobacco use. That's why tobacco use is associated with a higher risk of stroke, because a lot of people have carotid disease, but then that plaque becomes unstable with time. And when it's unstable, it's more inflamed, it's more prone to causing emboli. And that's why we want to put these patients on a high-intensity statin. That high-intensity statin has been shown to stabilize the plaque. So what I tell patients is, think of the statin as like, it's like an ibuprofen for your plaque. It causes anti-inflammatory activity within the plaque, which stabilizes it, and that reduces the patient's risk of stroke. Super important when we're going to go to treatment, both for CEA and for carotid stenting. So let's talk about carotid disease as it relates to stroke. So carotid artery disease is probably responsible for anywhere between 20 and 30% of ischemic TIA and stroke. What are the other causes? So one is just small vessel infarct, right? That's more associated with hypertension, just to get that kind of basal ganglia, hypertensive stroke. The other is cardioembolic, probably the most common, cardioembolic. So we want to make sure that all these patients get an EKG. That's why the cardiology consult's so key. They should get an echo. They should get all these things done before we make a decision whether or not to intervene. A lot of times the hospitalists or the ED evacuees will just like get a carotid ultrasound on somebody. I'm not sure why, but they will. And then they'll say, okay, it's carotid disease, and the workup will stop. The workup has to be comprehensive. It has to have the ultrasound, the CTA, probably the MRI, and the echo. All those things should be done. It really should be driven by the hospitalist and or neurology, depending on their availability. Why do patients with carotid disease get a stroke? It's not because of a flow issue, right? The narrowing, whether it's greater than 80% or whether it's greater than 50%, the flow is not what's causing the stroke. What's causing the stroke is that as the narrowing gets more severe, it becomes a bigger shelf for little bits of plaque and clot to develop. Does anybody fish?
Yes.
Show of hands. Brad, all right, good. So you guys know if you ever go out on a river and you see a river kind of bending back and forth like this, as the river bends, okay, as you go past that bend, you get this little eddy, right? Like if you're in the current, you know that if you swim over to that inward side, past the bend, the water slows down, you're going to be out of the current a little bit. It's the same thing that happens with a carotid plaque. If you look over here, this is the ICA, right? Just like in a river where there's a branch point, you get sediment deposition along the banks. After you pass that, right here there's going to be a little eddy, okay? So the blood flow is going to be going up to the carotid, and right past this plaque, you're going to get a little bit of slowing down. That's Why? When you get it more narrow, it causes more slowing right here, and there's more of a chance for plaque and clot to just sit there, and as it sits there just for a moment, if the patient's got a predisposition to forming clot, like if they're smoking, if they've got other inflammatory disease, if this plaque is very inflamed, so it kind of irritates the blood that sits right there, you get that clot development that goes up and causes a TIA and causes a stroke. So what are the signs and symptoms of TIA or stroke? So oftentimes we get called for things that aren't related to carotid disease. So unilateral numbness and weakness, super important. Somebody said both my feet are numb, not interested. Both my hands are numb, not interested. Unilateral numbness and weakness, and it has to correlate to the opposite side of where we see the lesion, right? If they've got a left 50%, left less than 50% stenosis, and they're complaining of right hand numbness, I'm not interested in the carotid. And that's been shown that if we go and fix those carotid stenoses that are mild, we don't cause a reduction in the risk of subsequent stroke. What about visual loss? So I always tell patients the classic visual loss, and I try not to lead them. I try to let them tell me. If they tell me classically, oh, it's like the shade going across the eye, that's pretty classic. I'll say, all right, fine, that was a TIA. Ideally, it's like a blackout, like it's not just a blurriness in their vision. It's as though they can't see. Sometimes they'll describe it as black, sometimes they'll describe it as bright white, but they can't see anything at all. Sometimes it's just like the upper half of the eye, or even just a little quarter of the eye. Those are all legitimate symptoms, and so we should consider those as potential TIA. But if they say, oh, I've got floaters, or I've got cataracts, or I've got bilateral blurry vision, unlikely to be associated with carotid disease. What about speech problems? So the two types of speech problems that I tell people about are, number one, they're speaking to a family member or a friend, and all of a sudden their speech becomes like gibberish, and the family or the friend says, I can't understand what you're saying. The patient thinks they're speaking normally, but the family doesn't understand them appropriately. That's one symptom. The other is that they want to speak, they know exactly what they want to say, they're trying to say things, but they can't form the words. It's different than saying, well, you know, I stutter for a couple times, or I can't remember what I want to say, and I have trouble kind of thinking of the word when it comes to me. That's like normal. That happens to me all the time. One of the things to think about with speech is handedness, all right? So if you're right-handed, where's your speech center?
Left side.
What?
Left side.
Anybody? Out of
Left side.
left? Yeah, left. So left side of your brain. 95% of the time, if you're right-handed, your speech center is on the left side of your brain. If you're left-handed, is it 95% of the time on the right side? It's 50-50. If you're left-handed, it's 50-50. So who knows? If they've got speech problems, I hope they have another symptom. I can't really tell whether or not their carotid disease is associated with that other side or not. That's why sometimes we'll say, okay, if they're just having TIAs, we'll get an MRI and see if they've got any silent emboli, silent ischemic events. So for instance, if they're left-handed, they say, oh, they come in with speech problems, and they got bilateral 60% carotid disease, which side do you fix? So I either try to see if they've got other symptoms that tell me which side, like maybe they've got some unilateral numbness out of the face, or some facial droop, or they've got some weakness, or I get an MRI and say, okay, yeah, sure, on the right side, they've got a couple little areas of infarct in the carotid distribution, in the MCA distribution. And that makes me think that maybe this is a symptomatic lesion, we'll go and fix it.
I got 2 questions for you.
Yeah.
The visual changes, is that same side as the lesion?
Same side, Nate. Yeah, good question. So same side as the lesion, yeah. So I don't, you can get opposite side of the lesion if you have posterior circulation strokes. I don't really, to me, a posterior circulation stroke, a neurologist has to show me why I need to fix that. I don't think that the contralateral visual changes, I would get concerned about. Visual changes should be ipsilateral.
Okay, and then, the 70 to 99% stenosis, that's a no-brainer, and then less than 50, we don't, you don't want to hear about that. But what about the guy that has a stroke, on the right side, and he has left-sided ultrasound that shows 50 to 70? What do you do with that?
So let's say you got a guy, and they're consulting you because they said, oh, we did his stroke workup, and he's got that kind of stenosis that you talked about, but he had a stroke on the other side, and the other side is less than 50%. Or the other side, he's had a carotid done before. Well, if he's had a carotid done before, we've seen a couple patients together. or they have recurrent stenosis, and maybe that's missed by the ultrasound. That's important. If you get a patient like that, you really want to make sure they get a CTA unless you can't get it. Because the ultrasounds, I'll tell you, so what's the problem with ultrasound? Number one, it's operator dependent. So you get these velocities that are all over the place, and they don't tend to correlate with CT here. A good ultrasound lab will do quality control, and they'll check their ultrasounds against patients that had a CTA, and they'll see where they're missing things. And then they'll come back and they'll readjust their protocols so that they're not missing carotid patients that way. An MRA probably overcalls everything. And you'll see that. And good radiologists will say, oh, the MRA shows there's a stenosis, but we really can't tell you how severe it is because there's a lot of artifact. So a CTA is the better test to do for patients. What else? You asked about, the 50 to 70%. So, okay, so you have 50 to 70% stenosis, and you ruled out that it's associated, so the side that's symptomatic is like less than 50%. We would just recommend appropriate medical therapy, and we'll follow that patient up as an outpatient.
Okay, but it's
nothing else
possible
for us to do at that time. So aspirin, statin, follow up as an outpatient.
But it's possible that it could have been the cause?
No. If they have a right-sided, so there's a phenomenon where an emboli can go from one side up to the circle Willis and up to the other side. That's a diagnosis. That's not like, again, I think it's really important that neurology see and evaluate all these patients. I realize that it's not necessarily something that is available, although I think that HHC is trying to make that a priority. So I think we as a team should be pushing on the hospitalist team to get neurology involved for all these patients. You know, to teleneurology, I don't find it very helpful. I don't know if you guys have more experience with that than I do.
Same.
But yeah, if they've got a stroke on the right, and the left side is 50 to 70, you know, and the right side is like less than 50, don't worry about it.
Okay.
You can talk to us about it, that's fine. It's not, we're not going to do it different. All right, so should we fix asymptomatic patients? Okay, so these are people that you're going to see who come in that we care for, right? Because you might get consult on some asymptomatic patients. Should we fix them? So all this data, look at how old this is. These trials are from like over 15 years ago, and over 25 years ago. Because look, like the first trial, the ACAS trial, this was a landmark trial published in JAMA in '95. But the patients that were enrolled in this trial were treated way back in 1987. And I mean, who thinks we manage things in the hospital the same way we did in the late 80s? Totally different, right? But this looked at treating patients who were asymptomatic with greater than 60% carotid stenosis, and they were randomized to either an aspirin or a carotid endarterectomy. And of about 1,700 patients, there was a 5.1% risk of stroke with carotid procedure and an 11% risk of stroke with medical management alone. So the absolute risk reduction was 3% over about a 3-year period. All right. So then give about 10 years. They did the same trial in Europe, the ACST, asymptomatic carotid surgery trial. About twice as many patients, same criteria, same absolute risk reduction. All right. In fact, actually, same stroke risk between these two arms, which is kind of interesting. So within that late 80s to late 90s period, there wasn't a huge difference in how we managed strokes, in what the improvement we gave asymptomatic patients was, and in what the risk of medical therapy alone was, which is about 11% over this 3-year period. So what's an absolute risk reduction of 3%? What does that mean to a patient? That means that I will tell a patient that sits in front of me in the office that if I take them and I fix their asymptomatic carotid, that I reduce the risk of having a stroke by about 1% per year. A lot of patients, when you tell it to them that way, they're not super excited about going for surgery, right? So for asymptomatic patients, it's not as much of a game changer as sometimes people think it is. I will tell you one thing, both of those numbers, the 5% and the 11%, have both gone down, all right? So now the risk of a stroke with an asymptomatic patient is about 1%. If we go to a CEA, it's about 1%, it's very low, all right? But also with medical management, the risk of a stroke is only about 5-6%. So that's gone down too, by the same amount. So what's the difference between doing it, so why do a carotid, right? So number one, the annual risk of stroke with carotid is very low. It's less than 1% per year. But we front load all that. Almost all that stroke risk is in the first 30 days, right? It's the procedural risk and the peri-procedural stroke risk. The issue with some of the carotid stuff is that within the ACST trial, they did start using statins, but there was very poor statin compliance. Not all the patients who were in the trial complied with statin use. So it's hard to gauge, effective statins on the risk of stroke in that particular trial. What about best medical therapy? So there is a higher risk of stroke. And the other thing that's important for patients to realize is that it's what you call it pay as you go, right? So if I tell a patient I'm not going to fix the carotid, and instead I'm going to make them do best medical therapy, it's not as though after a couple of years the stroke risk goes down. Every year the stroke risk remains the same. So why is that important? If I've got an 85-year-old woman, women have a lower risk of stroke than men, okay? If I've got an 85-year-old woman who's got a 65% carotid stenosis, I mean, you know, she might live another 3 years, she might live another 5 or 7 years. Her risk of stroke is not going to be that high. I can probably just watch her fine. If I've got a 60-year-old man with a 65 or 70% carotid stenosis, he has a higher risk of stroke at baseline, and he's got another 20, 25 years to live, and then subsequently develop stroke. So there might be more benefit to me going in and fixing that patient as opposed to the older patient. So what about progression of disease despite therapy? What if we just choose to watch them? So if we have a patient with a mild to moderate stenosis, 50 to 70%, and we put them on the statin, we find that it's protective of progression. If we follow them over 5 years, about 11% will have some type of neurological event, of which almost 2/3 are strokes, okay? And about 45% in total, if we follow them every year, will progress to the next category of stenosis greater than 70%, or will have a TIA or stroke, all right? So you can tell a patient with 50 to 70% stenosis, we can watch you. The risk of us, the likelihood of us reducing stroke is fairly low, all right? So we can watch you with medical therapy, and your risk of progression is, you know, maybe 45%, but again, this is a somewhat older trial. I would argue that's a little lower now. What about if you have severe stenosis, so greater than 70%? Now, we choose a threshold of greater than 80 because we feel that that 70 to 80% range is not well understood. So we just have a higher threshold in general. That's our group's practice. There's some caveats to that, but I think, you know, by and large, it's a good take-home message. If you've got a severe asymptomatic stenosis, then within 1 year, 25% will develop some kind of neurological event. So much stronger evidence that you should go fix this severe category of stenosis. And the 5-year actuarial freedom from event is about 70%. If you have a greater than 90% stenosis, that 5-year freedom from event is only 45%. So really, really high-grade stenoses end up getting fixed because they're going to have a stroke or some type of other neurologic event. What do patients want to do? This is an interesting non-influence study out of the UK. So if you want to find really interesting medical management studies, you go to a country that doesn't have any skin in the game and nobody's trying to get procedures done. So you go to the UK and you ask patients, they basically just had a phone call and the patients were asked, imagine that you had greater than 70% asymptomatic stenosis. And they were given the risks that you had an 11% risk of stroke with medical therapy, a 3% risk of stroke with carotid procedure, and a 3 to 5% risk of stroke with stenting. Those are pretty real numbers, all right? And pretty good ratios between the different numbers. Almost half of the patients chose medical therapy as what they would want given that breakdown of the different risks of stroke and what they, you know, had in terms of diagnosis. So I thought that was kind of interesting in terms of what patients prefer when they're given the different options. However, if you look at how patients actually feel after undergoing procedures, this is looking at quality of life after carotid stenting versus CEA in the CREST trial, which I'll talk about in a second. So they basically found that with carotid artery stenting, patients had a higher patient quality of life satisfaction score at 2 weeks and 1 month. And mainly that was because they had less difficulty driving, eating, swallowing, less neck pain, less headache. But they did have more pain with walking and more leg pain, right, because of the femoral access. No difference in quality of life related outcomes between carotid stenting and CEA. But if you had a stroke or a TIA, which is more common in the stenting arm, then that was associated with lower healthcare quality of life at 1 year. Interestingly, if you had a nerve injury from your carotid procedure or if you had a post-op MI, the patients didn't seem to care about that within the trial. So this is why we fix symptomatic patients. This is the kind of landmark study of why we fix patients who are symptomatic and why we do a CEA on them. Again, old study, but it was so positive, it's never going to be repeated. And basically what we found was we took patients who had a symptomatic stenosis greater than 50%. They were randomized to medical therapy versus CEA, no stenting in this trial, carotid artery. absolute risk reduction was 17%, okay, which is huge. You saw earlier when I was talking about an absolute risk, not even a relative risk reduction, I was talking about an absolute risk reduction of like 3%, a little number. This is 17%. This is a way higher absolute risk reduction. 7% of patients within this trial who had CEA had a perioperative stroke, which is 24% who were managed medically. And most of that is within the first 3 months, which is why it's important that we try to get this in a timely fashion. When we repeat these studies, they found that you really want to treat a symptomatic patient within 14 days. Because after 14 days, they have a substantial risk of having another neurologic event. And once they've had another neurologic event, another TIA or another stroke, you may not be able to offer the benefit by intervening on the carotid. This is what I was talking about before, the less than 50%. That was included in this trial. There's no benefit less than 50%. So maybe it's an arbitrary cutoff. Yes, we have 48% stenosis or something. They've got a really ulcerated plaque. Occasionally, we will operate on those patients. But basically, that breaks down those. So what do our guidelines tell us? So basically, for the SBS, it says that we should intervene on the patient with asymptomatic disease and greater than 70% stenosis if we can offer them a perioperative risk of stroke and death of less than 3%. And for symptomatic patients, we should operate on them if their stenosis is greater than 50%, provided our risk of causing complication is less than 6%. So that's important. If I'm treating asymptomatic patients, but I'm a terrible surgeon, and my risk of stroke and death is 10%, I probably shouldn't be treating patients. Okay? That's why, A, it's important that we get all these medical management things ready. B, you don't want to just do one carotid a year. Let's see. I'm not going to go over the other guidelines. So we'll talk about stenting. So basically, why do we stent people? So what are the benefits of stenting? People thought, oh, well, CEA is good, but it's invasive, right? There's nerve injury risk, general anesthesia. So we'll put a stent up. So we'll do this thing. See this little umbrella over here? This is an embolic filter. All right, so this is supposed to protect from little bits of plaque and clot going up. When we put a balloon across this lesion, you see this narrowing here. Okay, so we put a filter up here. We do it awake. We do it under local anesthesia. What are the risks to this patient? Why isn't this necessarily, why didn't this catch on as being the absolute best thing ever? Well, one of them is that I've got to get here with carotid, right? So for all of you that have been down in IR and watched us do a procedure, how do I get here if I'm going from the groin? Well, I have to go up to the aortic arch, which means that I might flick little bits of plaque and clot into the other side and cause a stroke on the other side, even though I'm trying to fix this problem here. So this was the CREST trial. This is probably the largest comparison of stenting versus CEA, and I'll just run through some of the really important points real quick. So overall risk of stroke, that's what you care about if you're a patient, right? And it's true. Patients care most important when it's coming to carotid disease, they care about what the risk of stroke is. With carotid stenting, it was about 4%, versus CEA, it was lower. It was about 2.3%. So for, this is asymptomatic stenosis, all right? Risk of a stroke is lower with CEA than it is with transfemoral carotid stenting. What about heart attack? And this was any heart. This was just like a transient troponin elevation or a non-ST elevation line. These are not all stentings. And basically, the risk of a heart attack with carotid endarterectomy, open surgery, is about twice as high as with carotid stenting. So what I would tell a patient when they're asking me is, if you want to get a stent, your risk of MI is lower, but your risk of stroke is higher. If you want a CEA, your risk of stroke is lower, but the MI is higher. This has been repeated in other trials and in real-world data, and I'll just kind of go through a couple other things here. So this is where we talk about, this is the national coverage decision, high-risk criteria. So this is what Medicare says qualifies a patient as high risk. And this is important because in the United States, if you want to put a carotid stent in somebody for asymptomatic disease, the patient has to have high-risk criteria. Remember when a couple slides ago I said, oh, why do we do carotid stenting? It's because of these high-risk patients. That was the justification for doing stenting, that patients were going to benefit because, if they're high risk for surgery, they're going to have a higher risk of complication. So this is the same set of guidelines that apply to who we do a TCAR on. So anyone who has a TCAR should meet one of these criteria. And you'll notice some of them along the left-hand side are comorbidities. All right, so advanced age, CHF, abnormal stress test, uncontrolled diabetes, which is very vague, pulmonary disease. And then on the right side is anatomic conditions like prior radiation, which is a very scarred field, or reoperative field, if they've had a prior CEA. Tandem lesions, like you have multiple lesions, and also surgically inaccessible lesions. This is probably, in my opinion, the most common reason why I would do a TCAR on some of these, because I think they have a high lesion. A high lesion has a higher risk of nerve injury, and so I would rather treat that patient with TCAR. So this is basically, we apply high-risk criteria, and we look at stenting or CEA. This is actually 2004 to 2007, okay? And they looked at, for asymptomatic patients with overall had a 1.5 risk of stroke and death with carotid stenting and 1.2 for CEA, all right? Whereas for symptomatic patients with carotid stenting, the risk of stroke was way higher. So high-risk symptomatic patients, like the patients who we said should do better with stenting, actually do worse with stenting, way worse. Okay, so the risk of stroke and death with a high-risk patient is like 15%. So just to kind of break that down in table form, if you look at the risk of stroke with CREST, it's like 2.3% for CEA, 4% for CREST. MI, again, is higher for CEA. What about in the real world? The asymptomatic patients have a lower risk of stroke than for carotid endarterectomy versus stenting, and symptomatics have a much lower risk of stroke with CEA. So the take-home message from this should be whether you're high risk or whether you're low risk. If you're symptomatic, you really shouldn't get transfemoral carotid stent. Your risk of stroke for a symptomatic low-risk patient and a symptomatic high-risk patient are much higher than the risk of stroke associated with CEA. Skip that. Okay, so do we have another option? So this is TCAR. Are you guys familiar with TCAR? I know, Aldo, we've done one. Do you guys want to watch a quick video of what TCAR is?
Yes.
Okay, right. Hold on one second. Can you guys see my screen?
You can see your PowerPoint.
You see what?
Just the PowerPoint.
Oh, you still see the PowerPoint. Okay, hold on.
There you go.
Okay, I'm going to talk you through this here, and I'm going to kind of go. All right, so basically we position the patient as we would for a normal CEA. We prep the neck and we prep the groins too. And we do it in a way so that the neck and groins are both accessible and both covered. So this is a traditional CEA, right? We get the neck incision open, we open up the ICA, we clean out the plaque, and then we patch it, all right? And then this is, I think what they're trying to show you again, this is a traditional transfemoral stenting. And you can see the problem with transfemoral stenting here is that we have to cross the lesion. So basically what this video is showing you is we're causing debris to go up as we cross the lesion. Even if we put a little umbrella up top here, it basically, you know, it just by the fact of going past it causes us to maybe embolize. So TCAR, you can see the flow of blood is going the opposite direction. The flow of blood is going into this sheath while we're treating. And so when we deploy the stent, all the blood flow is going the opposite direction, away from the brain. And what's happening is the blood's coming up the other side over here, going through the circle of Willis and being sucked back through this little straw. And we'll show you how that works. So we position the patient, we make a small incision, we get the carotid artery out down here at the base, we put a little purse string suture in here, which is what this is showing, so that when we go to access, afterwards we can just tighten this down. We go in with a little needle, we put a wire here, we stop. We stop the wire before we ever go up past the lesion, and then we put this little drinking straw sheath in. Now we go and clamp this artery. Once we clamp the artery, the blood flow is not going this way, and instead it's reversing, it's going this other way. And the reason it's reversing is because it's high pressure through the arterial system, and it's low pressure here in the femoral vein, which is where our other sheath is. So we put a sheath in here and a sheath in here, and now the flow of blood has reverse directions within that carotid. So once we clamp the artery, now we have what's called flow reversal. Now the flow is going the opposite direction. It's now safe for us to put a wire up and treat that lesion. So you can see this is the little filter. There's no machine in here. It's just your body's own pressure that's creating the difference. We want this toggle switch. It's important. You guys are in this procedure with us. But when we go to clamp the artery, we want this toggle switch to be set to high, always, all right? If a patient is awake and they're having some neurologic changes, or EEG changes, and we're monitoring them, then we may switch to low. But if you guys are in the procedure with us and you see us doing this, you want to always make sure this switch is set to high, all right? Because we just want as much protection as possible. Then while we have that protected, we balloon it to kind of basically prepare it for a stenting. You can see all these little bits getting kind of shooken up. And here you can see all these embolic bits that would normally go up to the brain, and instead they're being sucked down into the sheath here. And that's basically it. We close it, we get out. All patients, whether you do a transfemoral stenting, let's go back to my. Okay. All patients, whether you do transfemoral stenting, whether you do CEA, or whether you do TCAR, spend a night in the hospital. And mostly that's for blood pressure monitoring afterwards. Because when you blow up a balloon next to a carotid bowl, they can get hypotension afterwards. So let's see, talked about that. Basically, just to go over this, and this is important, if you look at TCAR, the risk of TIA and stroke in all the randomized trials has been anywhere between 0.8 and 1.9%. So essentially, the TCAR risk is all high-risk patients. So it's the only patients included with TCAR. So the high-risk criteria I showed you before, all the patients who are treated with TCAR are considered high risk, and the overall risk of stroke is about the same as CEA. All right, MI is substantially lower than 1%, and even for symptomatics, the risk of stroke is quite low. So if you look here, right, all high-risk patients, the risk of stroke with carotid stenting is about 15%. The risk of stroke with TCAR is about 3.7%, which is much more akin to what we see with CEA.
Can TCAR be used in an asymptomatic high-risk patient?
You just have to meet those high-risk criteria. Absolutely. So either, in fact, I prefer TCAR than asymptomatic, to be honest with you. Symptomatic carotids, I think they're higher risk in general. So who is TCAR not good for? All right, so what must they be? They either must be high risk, either by physiological, advanced age, diabetes, pulmonary disease, or an anatomic factor, meaning that they've had neck radiation, or they've had a prior CEA, or they've got a high lesion, or they've got tandem lesions. They must be either greater than 50% asymptomatic, or they must be greater than 80% asymptomatic. So not greater than 70, yet greater than 80, which is what the criteria we use anyways, all right? This is the must, and this is the take-home message today. They must be on dual antiplatelet therapy, 100%, no exceptions. If we're going to take a patient with TCAR, our risk of stroke is 100%, in my opinion, in 99, related to the medical management. It's related to the medications they're on. It's a very safe procedure from a technical standpoint, but if they're not on the right medications, they're stent and thrombose. And I've seen it happen. I've never had it happen to me personally, but I've seen it happen to 3 or 4 patients now where their stent is thrombosed. And once that starts happening, you think about it, like I said, if you do 1 carotid a year and you have a stroke, your stroke risk per year is like 100%. So we have to make sure these patients get through this procedure as safely as possible. And the best way to do that is like that Swiss cheese approach to risk reduction. We all talk about it here. We all internalize it, and we all have the discussions we need to have with each other if we're worried about a patient's medical management. It means that if any of you are ever worried about the meds the patient is or is not taking, you raise your hand and you say, listen, I don't like this. This patient said that they're not taking this medication. You're supposed to be on it. We shouldn't do this procedure. All right? And any one of us should 100% back you up on that all the time. So what are the meds they need to be on? They need to be on an aspirin. If they've never taken an aspirin before, their first aspirin should be at least 4 hours from the procedure, ideally the day before, and should be a loading dose of aspirin, which we almost never give. And that's 2 325 aspirins. 650 milligrams of aspirin is considered a loading dose. Most patients are on an aspirin, and in which case a baby aspirin is fine. They don't need to be reloaded. But we really have to make sure we clarify that they're getting their aspirin daily. This is really important when you're in an inpatient that goes to TCAR. Because usually application. But everybody's different. Every patient gets different instructions from different docs. It's important for all of us to be on the same page. You want them to be on a baby aspirin daily. You want them to be on either Plavix or Brilinta. Now, I prefer Brilinta because it has a higher response rate. Brilinta or ticagrelor, the loading dose is 180 milligrams. It's 2 90-milligram tablets. And the medication is taken 90 milligrams twice a day, which is important. Plavix is only once a day. So patients have to understand they got to take the Brilinta in the morning and in the evening. When a patient comes in for a procedure, electively, one of the first things we'll do when we pre-op them is we'll say, all right, when was the last time you took your aspirin? When was the last time you took your Brilinta? If they tell me that somebody told them to stop their meds 48 hours before and they haven't had either, I will reschedule the case. I will not do the procedure. All right, I will send them home and say, sorry, you got that instructions, that's wrong. I would prefer if they took their baby aspirin and their morning dose of Brilinta before they ever came in that day. But if they tell me they took their last dose the night before, I may give them a Brilinta in the morning and I'll probably be okay with that. It's really important that before they get any sedative, we kind of go through that list and talk to them about it. Same thing, they need to be on statin medication, all right? And ideally, they should be on a statin for more than 7 days pre-op. I would also prefer that they be on at least one of the 2 doses of high-intensity statin. So either the lowest dose for high intensity is either Crestor 20 milligrams or Lipitor, atorvastatin 40 milligrams. If they're on one of those, then I'm fine. That's the take-home message is they have to be on an aspirin, on either Plavix or Brilinta, and they have to be on a statin. They have to be compliant with all of them. We want to know the last time they took those meds. All right? I think that's it. Oh, yeah, the best therapy for stroke prevention is CREST-2. I wouldn't worry about that too much. Basically, we're trying to answer this question. CREST-2 is the same as that CREST trial I talked about that came back in 2010. We're trying to figure out whether or not the current medical management lowers somebody's risk of stroke more than any type of surgery or nowadays. But I think that would be helpful with some of our higher risk people. Questions, guys?
Can you talk a little bit about like imaging? We touched a little bit about. So like if somebody has a CTA and then they call us, is there any value of an ultrasound, or you're okay with just a CTA?
Well, I'm okay with just a CTA. If they have a CTA, I'm going to ultrasound.
Can you turn that one back up? And then you mentioned a little bit about like stroke distribution, like vessels. So none of us are really any pros of neurosurgery or neurology. Like MCA distribution you're talking about, is that where most of these strokes occur? If they happen somewhere else, are we less concerned?
Yeah, so if you have a stroke and it's associated with the carotid, it should be an MCA distribution stroke, maybe anterior cerebral artery, all right? But that means it should be up in the cerebral hemisphere here, right? So if you think about the model of a brain, you've got your cerebral hemispheres, and then you've got your cerebellum and stuff like that down at the bottom of your brainstem. Brainstem strokes and cerebellar strokes are not carotid strokes, period. If you've got a cerebellar infarct, that's a posterior circulation, full posterior circulation. That's like basilar artery coming up through the vertebrals. That's usually either associated with this small vessel disease right there, like either a hemorrhagic or acute ischemic, like the vessel just clots, or it's associated with a vertebral artery stroke, which is super rare. So if you've got, if I say MCA distribution stroke, I'm really talking about the cerebral hemispheres, most likely being the MCA, which is the middle, like kind of half of the hemisphere, and the fronts and the backs are going to be anterior and posterior, like parietal lobe, frontal and parietal lobe. They can be associated with carotid distribution, but it's, especially parietal lobe can also be posterior. So what I would tell you is that if it's in the cerebral hemisphere, like up here in the middle, can't remember what lobe it is, but it's not the frontal, it's not the temporal lobe. If it's like temporal lobe, or if it's frontal, then I would say it's most likely to be carotid related. If it's parietal, it could be carotid related. If it's occipital, it's less likely to be carotid related.
Okay.
Neurology. Anything else, guys?
When's the next T-car?
I don't know. I'm gonna go to clinic. Maybe I'll find one. Maybe one of the main patients is symptomatic.